Hello again. I'd like to discuss with you during this lecture a pain generator approach to the management of people who come in with chronic pelvic pain. Why this lecture? Well, I think it's really important for everyone to understand that where we think the pain is coming from may not be coming from that specific area. And also, many patients come in thinking that the pain is coming from one specific organ or the muscles or what have you, when in fact it's coming from maybe multiple sources. So this lecture is really devoted to how we try to figure out what is going on, where the pain is coming from, and how to attack it most effectively. Well, first of all, as I alluded to, lots of people misinterpret where their pain is coming from. A perfect example are men who come with pelvic pain, but they come in with pain at the tip of their penis. There's actually no problem at that point. Really, the problem often is coming from deeper inside the pelvis, whether it be the prostate or the pelvic floor musculature, or even the nervous system. There can be multiple sources of pain, as I mentioned previously. And for example, patients who present with a history of interstitial cystitis, bladder pain syndrome, we often find that, yes, they are suffering from pain related to the bladder, but there may be other sources that are side by side. And in fact, in this particular pie chart that you see over here, this patient has 55% perhaps of their pain from bladder sources, but there's a lot of other pain generators present, whether it be the pelvic floor muscles, that's the PFD, pelvic floor dysfunction, vulvar pain syndrome, such as vulvodynia, and even irritable bowel syndrome. This, of course, will have a great hindrance upon research efforts because, for example, let's say I had a medication that could just wipe out all bladder-related pain, and the patient has this particular pie chart present. Well, of course, only a little more than 50% of the pain at max would be alleviated. You're still left with pelvic pain. And the patients would show this on their symptom scores. They're still having pain. The medication looks like it's useless, but in fact, it really, if you just look at the bladder pain, it would have been useful. Sources of pain may feed upon each other, and a perfect example of this is the bowel-bladder connection. Oftentimes, when the bowel is having a problem, usually problems such as constipation, it may worsen bladder dysfunction. So we may need to treat other sources of pain to have an effect even on other sources of pelvic pain like the bladder. There are lots of vicious cycles that are present that may even perpetuate the pain. And a perfect example of this is found with the pelvic floor musculature. When it starts to spasm, as you can see here, pelvic floor spasm, the muscles are tender. There may be little taut bands of discomfort called trigger points present. When that particular problem exists, patients may have all sorts of symptoms related to pain, changes in the way the urine flows, urinary hesitancy, even problems with constipation and sexually related pain. And unfortunately, our own normal, patients tend to respond to some of those problems by straining. So if you have urinary hesitancy and that hesitancy is based on pelvic floor spasm, you actually strain the muscles more, and then you have more symptoms. On top of that, let's say you have pain in your pelvis and it may be related to bladder floor spasm. What do people naturally do? They tend to guard. They actually tighten up rather than to relax it out. And that's another little activity or behavioral aspect of this condition that tends to keep this little process of worsening pain in motion. And then you add to this, of course, existing conditions such as vulvar pain syndrome, irritable bowel syndrome, fibromyalgia, even a simple urinary tract infection, along with interstitial cystitis, the bladder pain syndrome, all sources of pain. You tend to guard more, you tend to push more, and again, that spins the cycle. And finally, the last straw is, of course, your stress increases. And what do you do then? You tighten up. And also the physiologic aspects of what occurs during stressful situations can worsen pain altogether. So we need to reverse these processes, and that's so important in the care of patients and getting better. We tend to also think that pain is just from the pelvis. And there was a very interesting study, one of the hallmark findings of the MAPP Epidemiology-Phenotyping study. MAPP is the multidisciplinary approaches to the study of chronic urological pelvic pain. It's a well-funded NIH project that's been going on for the past 10 years. One of the hallmark findings is that about 3/4 of patients tend to have not just pelvic pain, they have pelvic pain and beyond. We're marking off, as you can see on these body maps, pain in all sorts of different areas of the body, suggesting that this may be a centralized type of global problem for many, many people. And we need to address those issues. To make matters a little more complex, there are all sorts of different forms of pain, whether it's somatic, as you can see the little pinprick over there, you know exactly where it is, which finger the pin is going to, and even where on the finger the pin is hitting. Visceral pain is the type of pain that's we see lots and lots of times in the pelvis. And this is the type of pain, it's really hard to describe where it is. It's just hard to describe its character in many instances. It has an emotional component to it. And this is probably one of the most difficult types of pain to identify the source of and even to treat. And of course, there's neuropathic pain that may be from the end organ itself, like the bladder, but there may be central aspects to pain. The pain may be festering in the spinal cord or even the brain. As you can see on this diagram, on this functional MRI study over here, there may be functional changes in brain, changes in brain activity, and even anatomical changes. Whether it's a cause or effect relationship related to the pain is unknown, but clearly there are neuropathic issues involved in many patients that need to be addressed. I mentioned before about the one pain feeding upon another, and this is a perfect example, what we call the bowel-bladder connection or organ-organ crosstalk. You can see here how the bowel, when the bowel becomes dysfunctional, it can have an effect on bladder function as well as pain. It seems to sort of go in one direction clinically more than the other. So when the bladder is having a problem, it doesn't seem to affect the bowel as much, but certainly you can see it from the bowel to the bladder. There are also other issues involved in figuring out where pain is coming from. We see a lot of referred pain. And in this diagram, you can see the nerves that go to and from the pelvic floor muscles over here. And they have a similar input into the central nervous system as the bladder. Now, keep in mind, they have to work together, but that also gives us problems in terms of sometimes problems with the muscles give bladder type symptoms, and problems with the bladder can give muscle type symptoms. So that's why it's so important to really do a very close, a very comprehensive history taking and physical examination to sort of better define where the problem truly is coming from. And often we need to treat both issues at the same time. This also reflects something quite interesting, the fact that patients with interstitial cystitis, the bladder pain syndrome, about 80–85% of them will have pelvic floor problems as well. Pain can be difficult, not just from the standpoint of where it's coming from, but how it fluctuates. And we wish all patients, not that we wish pain on anyone, but if you're going to have pain, it's better to just have it straight across over time. Pain severity over time is pretty much stable, but that's really not how it works. Pain can fluctuate every hour, can fluctuate during the course of a day, a week. Patients have symptom flares, and we need to keep this in mind when treating any given patient. We're going to go back to the basics again, trying to find these pain generators. And this is sort of called the cauldron of pain. We have to try to figure out where is the pain, what type of process is going on. And in order to do that, we need to go to the basic concepts of care. We need to identify pain generators, because lots of patients have not just one, but maybe 2 or 3 pain generators, and we need to address them to get the best effect. Of course, history, physical examination, and sometimes we need to do laboratories, x-ray studies, ultrasounds. Sometimes we need to perform cystoscopy to actually see, is there inflammatory disease in the bladder, urodynamic evaluation to identify any changes in bladder in urinary function. And then it's a matter of peeling the onion, identify and then treat, and then see how patients do. At least that's how we do it, and multiple centers around the globe do it as well these days. Here's a typical patient who may come in. I'm not throwing the easy ones at you. Someone who comes in with lots of problems. It's a 36-year-old female. She carries lots of diagnoses, including fibromyalgia, pelvic floor related pain, vulvar pain, and also has interstitial cystitis. And we may ultimately, after that type of peel the onion approach, come up with a strategy of care that may include a whole bunch of very simple things and more aggressive approaches to care. What goes to which you can see here in this very complex bunch of arrows, but I just want to bring to your attention that there are some problems, for example, pelvic floor dysfunction, that really deserves a special attention. We may apply muscle relaxants, specialized physical therapy, even may inject these muscles specifically with muscle relaxants, with anesthetics, etc. But there are some agents or some therapies that might basically, it's the sort of the one stone, many birds. I hate that analogy, but we're taking a look at amitriptyline, one medication that has been historically used for interstitial cystitis, but its pain relieving properties may improve the symptoms of fibromyalgia along with the interstitial cystitis. And this patient also has vulvodynia. It may have a favorable impact on that condition as well. So we try to sort of organize therapeutic approaches to address all the different problems in as simplified a fashion as possible. Sometimes we need to do more advanced treatments and for specific problems. And this is sort of a little bit of, I guess, a show and tell, if you want to call it, sort of a pictorial approach to what some of the therapies available. You can see here in the upper left-hand corner, specific injections of the muscles that might be tender. This is not a first-line approach for most patients, but clearly it's for patients who've sort of reached a plateau in terms of the care. We're just not responding. This can be quite helpful. When we can move off to the right side of this slide and see a patient who comes in with a Hunter lesion. This is this little focal area of inflammation. We can fulgurate it, that means to burn it. You can see this outside inflammatory event that occurs, but just by doing this, most patients, the vast majority of patients, will have rapid symptom improvement. We've been advancing that technique further, as is done again globally these days, and injecting triamcinolone, which is steroid, into the region. Here you can see little deposits of the triamcinolone underneath the bladder surface, and what do you not see? You don't see any further inflammatory disease here. So that's a real big win for many patients as well. Typically, when Botox is used into the bladder, it's used for overactivity of the bladder, and you can see it's dispensed in multiple areas. When we use it, we have been using it off-label, as many centers do, for the treatment of interstitial cystitis. It's part of our guidelines, and you can see when we apply just to this bottom area, which tends to be the most sensitive area, many patients have some improvement in symptoms as well. We move on to some more experimental models. Here you can see this is a description of the use of liposomes, small fat molecules that can surround, in this case, a little droplet of water, but they can also surround medications. And this is what we call a vehicle that can bring perhaps medications to the surface of the bladder, or even other surfaces of the body. Jen has discussed some of the basic issues will be discussing the basic issues regarding cannabis. There are cannabis receptors in the bladder and elsewhere in the body that working with these specific agents may have some potential. You can see here the use of what's called neuromodulation, ways to change the way the nerves interact with the bladder and the pelvic floor. You can see these little leads in place. And we're hoping to see more research and work done on how this might help some of our patients with pelvic pain syndromes. And of course, over here, you can see this little side view. This is called a sagittal view of the human body. This is the bladder, and this very, very skinny little catheter that goes directly into the bladder, which is capped off. And recently, we've even been having our interventional radiologists place these little catheters. And the concept here is for patients who really can't tolerate, or for whatever reason we don't want to place a catheter into the urethra, perhaps because of pain or other reasons, we can put it directly over here. patients can then instill medications all by themselves, cap the tube off, and we can put them through a treatment plan like this. But this is, again, for very selective patients. So in summary, we're going to end over here. Really, the true take-home message here is that pelvic pain is most commonly multifaceted. We usually see not just the bladder or the prostate or the pelvic floor, we usually see a combination of problems for many patients. We need to address those problems. And in doing so, even all the way up to the central nervous system may be in order for many patients. Effective therapies for one problem may have a benefit for other sources of pain. We often treat the pelvic floor problems, bladder pain improves. We treat the bowel of chronic constipation, or the patients do, or their gastroenterologists do. And again, much of their other sources of pain, whether it be the bladder or the pelvic floor, start to improve. So we really have to look at a more holistic approach for patient care. And of course, future therapies really will be developed based upon all the different pathologies that we identify and the specific, what we call the phenotype, how the patients present to us. So I hope this was helpful, and I wish you a very good day ahead.